Hey everyone, welcome to Baltimore County Fire Department EMS Academy. For those who I haven't met, my name is Sean Barinholtz. I am an anesthesia and a critical care physician at Hopkins. I'm an active member of Pikesville Volunteer Fire Company in Baltimore County, and I have the honor of serving as one of the associate medical directors for Baltimore County Fire Department. On behalf of the EMS office, Captain Nats, the EMS Training Academy staff, and Captain Stewart, thanks for what you guys do every day. Thanks for being here and your commitment to lifelong learning. Big shout out to Ashley Brooks, who helped us generate a link for our CEUs and helps us manage the platform. Ashley won't be able to join us tonight, so please feel free to text me if you have any issues with the platform. We will be sending out a link closer to the end in the chat. I'll let you know as well. Click on that link, fill out some basic information to get your MIM CEUs. If you have any questions about your past participation, MIM CEUs, continuing education certification options, please stay on with us after this training, and I'll see if we can answer your questions. So tonight, super excited and honored to have with us Suzanna Fitzpatrick. Suzanna is a nurse practitioner at the University of Maryland Medical Center, where she has worked since 2008. She is a senior nurse practitioner with expertise in surgical patients, transplant oncology, emergency medicine. She began her healthcare journey as a paramedic in Montgomery County, which she still continues doing as a volunteer for the past 20 years. Her educational background includes a Bachelor's of Science from UMBC in Emergency Health Services, a B.S.N. from Villa Julie College, Master's in Nursing and Acute Care, Postmaster certification from Graduate of George Washington University in Family Practice, and her doctorate in nursing practice. I also learned that she is now in another doctorate program in addition to raising 2 young children. Her doctoral work focuses on teamwork and collaboration with emergency nurses. Suzanna has a passion for mentoring and teaching. She is exceedingly well published, and she is the co-founder of the healthcare leadership community of the International Leadership Association. Suzanna, thank you so much for being with us. Thanks for what you do and your commitment as an educator and as a mentor.
Thanks. And you guys all got to see my little 7-year-old say, Mommy, I have something in my eye. So, it never stops anywhere for any of us. Well, thanks so much for having me. I have been listening to these for the past probably like 6 to 8 months. And they've been really helpful just to learn something else and take a platform in a different way, because we're all really busy. So for me, it's been really helpful. So I was glad to be here. So today we're going to be talking about palliative care, and you'll find out shortly why I'm really interested in it, why it's important to us as paramedics, what is hospice about, some common myths about hospice care and implications for practice. And Sean, you're going to run these people in the room wanting to get in, I hope. So what is palliative care? It's focused sort of on caring for the patient and the family, not just curing the patient. This can happen at any time for any age of patient and any stage of serious illness. Symptom relief is really the biggest part of it, but people are just not sort of into what palliative care means. I work for a surgical service. Normally, if I say, "Ooh, what do you think about palliative care?" They say, no, we're not giving up on the patient. And I go, no, that's not what it means. So we're going to start learning about it together. So some of the essential pieces of it, just so we can start having an understanding before we talk a little bit further what it means for us. So this means that we're thinking about palliative care for a patient, that we're really committed to decreasing symptoms that are affecting their daily life and improving quality of life. And you'll hear that term a lot, and everybody's quality of life is a little bit different. If you work with patients regularly, you'll know that sometimes what their quality is not what I think quality would be for myself, but if it makes them feel good, I want to be into that. I really want to make sure that I'm in line with their beliefs and value systems, and not put my own prejudice of what that means. And understanding what a goal of care is. Again, I work with surgeons, so if I have a difference of goal of care, and that it's not surgery and it's not necessarily maybe leaving with an outcome where they all have extension of their life, but they have a quality of life, that's what I'm about. Talking to their patient and talking to their friends and talking to their families is really important, as we get not just a holistic lens of what's happening with them, but really making sure we're hearing the important people in their life and how we can help them. So briefly, just thinking about hospice, which is a little bit different. So hospice is a Medicaid term and a Medicare term, and there's some criteria that means that. It usually, from a system standpoint and a state standpoint, it's that you have a non-curable disease that we think will probably end your life at 6 months. And we can't, see the future. But if you have a metastatic terminal cancer, you're not seeking to do any chemotherapy and radiation. That would be somebody who probably would qualify for it. If, for example, they had metastatic colon cancer, which has a life expectancy of 22 months, and they have had progression of disease, they would probably qualify for that. And that is very similar in terms of a holistic lens of looking at the people who are taking care of them, not just the patient, but their family members, or who they consider their family members. It doesn't have to be their spouse. It doesn't have to be their kid. It doesn't have to be their parents. It could be somebody who's really important to them, who's going to be with them as they continue on their journey for the best quality of life that they can have. End of life care does not hasten or postpone death. It's a really important piece. It's not assisted suicide. There are some areas in the country that do that, and we will not be talking about that, but this is just being with them as they progress in their next journey of life. So here, I love a little bit of interaction. So has anybody ever transported a patient who they thought might have qualified for hospice, or maybe was enrolled in hospice? Do you think you did the right thing? Was it because the family was afraid? Is that why they called 911 and they had unanswered questions? Did you not spend the time looking for the DNR and you took them to the hospital anyway? Or was it because you think our job is to take the patient to the hospital no matter what is going on with them? And then as we think about those answers, and you can either type them or you can have some self-reflection on that, where do we want to be when we want to die? So I think we will all probably agree, if you've ridden 911 for more than 5 seconds, that we probably did things in the beginning of our career that now that we're older and smarter, we wouldn't have done later on. And thinking about when 911 is called, or if you're doing interfacility transport, or you're spending time in the hospital, at the beginning of our time, we're so amped up to fix them that sometimes for sure, when I started EMS at age 19, I wanted to fix them because that's what I was taught to do. My job is to do all the medicine and the trauma that I knew how to do, but not perhaps sort of pause and say, what's the end? What's the global lens? What am I doing for them if I take them to the hospital? So I really like this quote, have no regrets. The elderly usually don't have regrets for what we did, but rather for things we did not do. The only people who fear death are those with regrets. And I think that's an important thought. So nobody wrote in there of things that inspired them about hospice or not, but I'm sure certainly when we go to nursing homes or long-term care, the first thing sort of people ask is like, do they have a DNR? Well, what does that mean? Why do they have a DNR? Is it because they just don't want compressions? Is it because they have metastatic cancer? Just because you're a DNR doesn't mean you're in palliative and hospice care. And it doesn't necessarily mean that anybody has ever talked to them about those things. So the reason I really care about this is my mom. And you can see at the top right, that's me and her when I'm little, and her in the middle. And then as she progressed in her metastatic cancer, that's her and my son, who's now 10. He's probably maybe 2 there. And then at the end, we were able to bring her home, which was great. And she got to pass with me holding her hand, and 2 of my best friends. And I was very, very grateful that we had that opportunity. So sure, there was other things we could have done. There was other treatments she could have had, but was I doing the right thing for her? And when she called me on the phone the Tuesday before she died and said, I don't want to do this anymore, I just want to go home and be with you, I had to say, okay. And so I called the fire department and said, hey, I need to bring my mom home. And they helped me do that. And there were some questions as, why are we doing that? Why not do one more thing? And everybody's personal journey as they progress towards the end of their life, we all want to be with the people who love us the most. And so we were able to do that. So that's one of the reasons I like this. And you'll hear another reason with mobile health as we get a little bit further. All right, so some background in just thinking about it. So we want to give the best care that we possibly can, but sometimes we don't exactly know what it is. And I like this wish list on the right of things that we want as we're progressing towards the end of our life, of whatever that may be, and things that come into focus of those things. And you notice that none of them really are talking about medicine and cure and medication and hospitals and medical providers, but they're talking about basically peace and happiness that you might find within yourself. So 80% of people want to die at home, but 45% die, but only 45% do. Most people die, more than 50% die either in a hospital or a long-term care. So we're really missing the opportunity to bring people where they would like to be. So I want my family to be home, but I'm afraid, right? I'm enrolled in hospice, or my family member is, but I got freaked out and I'm now calling 911. We show up there. And so most of these patients want to be home. And then as they sort of progress in their disease and maybe their orientation is not as good, we get afraid. And watching somebody die, as I'm sure probably most of you have, it can be vulnerable and fearful, and we want to help. And that's what we're trained to do. We all became EMTs or nurses or anesthesiologists or paramedics because we want to help people. And to watch somebody pass away when you're not doing that thing, the physical act of help, but you are helping them emotionally pass in their next stage, is just as important, if not more so. So I don't know if any of you have arrived on a house someplace, somebody called 911 because their loved one was enrolled in hospice, and they got freaked out when they started getting gurgly, or they started getting short of breath, or started feeling like gaspy. And that is a real thing. And we don't do a lot of education when people have a terminal disease or a disease the patient doesn't want to cure. And then the family is left at home. And most of us, would be fine probably watching somebody pass away, as emotionally heart-racing as it might be. But non-healthcare people watching that is very, very scary. And we don't provide any support to those caregivers as they're progressing to their next stage of life. So I have been a paramedic on that call. I got a 911 call for somebody with shortness of breath. We get there, the patient is a DNR, the patient is enrolled in hospice, but his wife is there and he's watching him gurgle, which he had been doing for some time, but it had been getting worse. And hospice was not there. And we'll talk about why that is in a short bit, but basically most of the family needs to do all of the hospice care. And so there was this fear that was happening around this gentleman's family because they weren't prepared for the next stage. And that in-between stage between sort of being alive and dying can be very, very anxiety producing, emotionally taxing, and fearful for the family, because our greatest fear for all of our loved one is suffering. And to see somebody like that, while it's not exactly suffering, it's not exactly a pleasant passing. And that communication we can do, I think, better. And so I think we're in a great opportunity. I arrived on the scene. I was very young. I did not know anything about palliative and hospice care. I had coded people, but I had not really been present with somebody on a peaceful passing of their death. And I didn't freak out in terms of didn't know what to do, but was very perplexed as to why somebody would be in hospice. Hospice nurse was not there. Why was the family member calling 911? That part I just didn't understand. And I'm not sure that most of us understand unless you're sort of in this work. And that's the part I want you to feel like you have an understanding about. And it looks like Michael said, I had this exact call a few days ago. Do you want to share a little bit about that, Michael? I like more of an interaction. You can decline too. But I think this does happen.
Yeah, I can briefly share. We got a call for a gentleman, shortness of breath, trouble breathing, ALS1 call. We arrived on scene and found that the patient had just enrolled in hospice and was basically waiting for the hospice nurse to come back with oxygen. And it was about a 4-hour lag time before the nurse was able to come back. So when the nurse originally left, the patient started calling out to the family, gasping, kind of the similar situation that you described. So when we gathered up all the paperwork, determined he was on hospice and the nurse was coming back, I decided as a paramedic to then treat just what they needed at that time, which was just oxygen. So we left a few cylinders on scene, was able to get them through that interim period until the hospice nurse arrived back to the house with oxygen. And we were able to mitigate that without taking them to the hospital, which is not what they wanted to do. So I feel like 10 years ago, that would have been a different situation. Now, kind of catching up with what we know about, people's needs and their desires to stay at home and die well. We were able to kind of enter into that from an EMS standpoint in a very holistic way. So.
Well, that's really awesome. I would say, I for sure did not act in that way when I ran this call, but I probably would now. And if you consider sort of just the things we're supposed to do, right? We're not supposed to leave equipment with patients. We're not supposed to sit and call the nurse and call their doctor and delay. We're not supposed to have these long sitting at the house waiting, right? But if we pause for 30 seconds to go, what is actually the right thing? And what can we actually have an effect on? Is pretty powerful. So it sounds like you did a really awesome thing. I'm really glad you were able to share that. Thank you. And then it looks like Tina, who cannot talk out loud, she transported one day due to her family being scared and the pain was uncontrolled. DNR, patient did not speak English and felt she was burdening her family because they wanted her to go, unfortunately. And I think too, that's a really important piece, Tina, is like that feeling of burden. And so as even now, I mean, my husband and I, have our wills right now so that I mean, it's not, my mom thought it was awful, but like after 30 days, we don't want to be like trached and pegged. We don't want to go to a nursing home. We don't want to put that burden on our children and our families, because he and I have a very transparent conversation about it. And both of our parents died on hospice. But lots of people don't have those conversations. And then you feel yourself getting older and vulnerable. And maybe now you need help with toiletry and you need help eating. And then now we feel like a burden to these people that we have raised or surrounded ourselves with, to be independent. So thank you for sharing that. Dr. AJ said, I was my mother's full-time family caregiver in her home until she took her last breath. The physician at the hospital said he rarely sees a patient coming from their home instead of a facility. He congratulated me in caring for her patient. She died of heart disease. Thank you for sharing that too. And I think, showing up at a nursing home, I think we all have done it. You get a call, you hear some words of, she's a DNR, there's no paperwork. You're sort of at that pause, not sure what to do. And then you have to move forward and you took the patient to the hospital, right? Because always acting on the side of caution for the patient is the right thing. But is there another opportunity of starting to like get moving, going to the hospital while we have the nursing home on the phone, or we have them call the doctor on call to see if they can fax it to the hospital? I certainly have not done that extra step, 20 years ago, but now I try to make sure to do those things so that people can get the care that they really, really want. So thanks for sharing that. But it's pretty taxing. So I pulled a lot of articles on this and there was a lot of quotes from people and I liked this one. He was just getting weaker and weaker by the day. I called them and I said, I'm really alarmed. He's really getting weak. He's having a hard time just getting up and going to the bathroom. And the woman sort of said to me a little abruptly, well, that's the nature of cancer. And I just thought, oh, I didn't know why, but you didn't mention it. And I didn't make that connection. So we do a bad job of explaining to patients and their family members of what the end will look like and what it will look like when things get hard and what to do when it gets hard and how we can help make the hard even less. And it will be emotionally really, really hard. And I don't take away the journey that sounds like a few of you have been on with your family members, because it was really, really hard for me. But we're just not good about saying to the patients and saying to their family members, when you pick up the patient who is 90 pounds at their house, who's short of breath, who, his wife says he has metastatic cancer, are we having a conversation with them? Like, this is really hard. I'm really sorry you're going through this. We're going to do everything we can that you want for a quality of life as long as you can have. I like this one too. I know why we try to keep the dead alive. We try to keep them alive in order to keep them with us. I thought that was pretty special too. So these deaths of the care recipient are often the first time they've ever had an encounter with death. So these people who are tasked with caring for their loved one for as many days or weeks or months as it takes has never had any interaction with death and what that looks like and what the heart is going to be. And as we'll see later, hospice is really only there to sort of check you in and be available for on call, and usually like 2 or 3 times a week, they'll come for like 30 minutes, but the rest of the time it's you. And you're just sitting there with this person who's eventually going to pass either in front of you or near you or things like that. And we don't have a conversation of what that looks like. So the Institute of Medicine is a pretty big institute that we follow a lot of their guidelines. And it's why aren't we using it more? So there's lack of resources. We sort of know that. Most of us don't know what resources exist and how to even do those things. Not having an understanding what palliative and hospice is, reluctance to refer. Can we refer patients to hospice? Does it only have to be a physician? Does it only have to be in the hospital? How come we don't know that piece of information? Or the patient and family member is not ready. And I'm sure, we have all been on calls where a husband and wife, or a wife and a wife, or a mother and her daughter, they're fighting about the care and who should go to the hospital, who should not go. And somebody's saying, please, mom, please just go to the hospital, go to the hospital. And mom is saying, no, I don't want to go. I don't want to go. And I can hear the sort of fear from the daughter not wanting this mom to go, or wanting her to go to the hospital because she doesn't want her to suffer. And the mom's like, I don't want to die alone in the hospital. So, thinking about how to have a better stance on education, I think is a missed opportunity we haven't capitalized. And we don't have enough sort of from a money standpoint in this country to ensure that every patient every single time has this available resource if they want it. And I don't think everybody has to have it, but I think we're doing ourselves and them a favor by having a conversation that, it's available to them. And if they're not ready to talk about it, that's totally cool. And if they want to talk about it later, that's also great. So just thinking about what this means a little bit further, because it seems to be so confusing of what palliative means, is we're going to talk a little bit further about community paramedicine, but palliative paramedicine is a concept that I pulled from another article, and it's just sort of broadening our traditional role. I think all of us in EMS, from when I started 20 years ago to even now, we are doing more. There's more availability for us to expand our practice other than being 911, get in the ambulance, drive to the scene, take them to the hospital. There's more thoughts of what we should be able to do. There's more education we're able to provide. There's more just a broadening scope of practice, because I think there's a great opportunity for that is not capitalized. And so thinking about as palliative care, hospice care, end of life care, and quality of life become more the norm, and having patients with those things and having conversations about it, there'll be an opportunity for paramedics to not just take the patient to the hospital, but be collaborative in their quality of life that they could have. All right, so I love a little statistics of the why. It really helps me think about it. So this was just a report card from this cool website. If you don't know about it, it's Intro to Palliative Care. They have a ton of cool stuff, and you can get on for free, and PowerPoints if you're interested in this kind of things. But hospitals, urban hospitals in the city have a fair amount of palliative care programs. I work in Baltimore, so it's a conversation we have, and I work for surgery, that comes up, I would say, for, more than a few of our patients every single week, just so that we're not necessarily not doing the surgery, things like that, but sort of thinking about what their quality of life will be like before or after the surgery. So in October of 2019, there was a Palliative Care and Hospice Education and Training Act that went into place. It had bipartisan support. So it's not a dividing line. I think we all want to not have as much quality of life as we can. So in that act, there was more money that went to Medicare to be able to support palliative and hospice training at all public hospitals. But you can see, if you are not living in a city, you're not getting that care as much as everybody else. There are palliative providers, so a special education of certificate program for physicians and nurse practitioners, but it's pretty low. But you don't have to have those specialty certifications to be able to do it. I can order anybody palliative and hospice care as they see fit and as they'd like to. And I don't have a special certification. I have an interest in it, but I don't have anything extra for that. So why do we want to do it? Well, yeah, we could say, yes, it definitely improves their quality of life, but everything is about cost in healthcare in addition to quality. So it really does reduce patient satisfaction, which is a huge driver of Medicare and Medicaid reimbursement. If you have low patient satisfaction scores in your institution, you get less reimbursement than everybody else. So they want the patients and the family members to write their Press Ganey scores that say they did a really good job. And then they'll get more reimbursement than everybody else. So we want the patients to be happy. We want their family members to be happy. And then in turn, there'll be a cost benefit for the hospitals. From outside the hospital, I think we all know that 33% of 911 calls are non-emergency calls. And would this be considered an emergency? Or rather, would it be an extended call? We're trying to figure out what the right thing is. So people who get on palliative care seem to really like it. Right. So being on palliative care doesn't mean that you die of your disease. It might just mean improving of your symptom management. Many of them do pass away, but it's not an always, but everybody seems to like it. I certainly do. I'm a big proponent of it. I think it's an exceptional thing that we should provide to every patient at every interaction in talking about surgeries or going to the hospital and what that looks like for them. So there's a bunch of different types of hospice, right? So there's an inpatient care. So inpatient hospital in Maryland, and we'll review what we have in Maryland. I pulled from the MIMS protocols. If you're an inpatient care, it means you have to get like IV medications in order to get your symptoms down. Home care is when patients are home, but those are the patients that are not getting seen very frequently by hospice, and the family has to be really involved to be able to take care of them. There is continuous care at home, but that means that means that there will be a hospice nurse there 24 hours a day or an aide. But oftentimes that is cost prohibitive for many people. To have a skilled nurse or even a medical assistant at your house is like over $500 per day. Hospice is less because some of it is covered with insurance for that 24-hour piece. Anybody can be enrolled in hospice and that is free of cost. But if you want the extra service, it's always about money. And then residential care, which is similar we have a couple of them, and there's one in Montgomery County where I am. Patients have their own rooms, their families can come be with them, which is also pretty nice. So inpatient is usually the hospital, home is home, and then residence is just like only a freestanding hospice area. Right, I'm still confused, I don't get it, right? It's pretty confusing. So palliative care is life-sustaining. It means that we are still trying to treat your symptoms. You can have it for any illness at all. You could have it for hypertension. You can have it for diabetes. If your diabetes and your hemoglobin A1C is 12 and you've got neuropathy in your feet and you can't really walk well and you're getting wounds, those things are not going to kill you in that 6-month period that will qualify you for hospice, but you definitely probably are suffering, and you probably have anxiety about movement. You don't want to go anywhere. Moving around. We never noticed how loud the clock was until Zoom started happening. But anyway, but it still focuses on quality of life. So there's still a multidisciplinary team that can help take care of you with physicians, nurses, nurse practitioners, social workers, and case management. But we're here, we're not prolonging your care. Hospice is that 6 months we talked about, which is a Medicare designation, and we're sort of preparing you for the end of life. So there are more conversations with you and your family about what it looks like as you get weaker, but to continue with your quality of life. Looks like Sean said agree. So just comparing them real briefly, if you like a table, which I do, and the part I want to talk about here is the payment piece. So every insurance in the United States will pay for hospice, both from an inpatient standpoint or for that home hospice care. Not the 24-hour home hospice. That's a separate fee. I mean, you can still get it, but everybody can have home hospice, which would include nurse visits, a hospital bed, medication that the family can give, a 24-hour nurse that's available for you to call if you have any questions, as well as social workers, physicians, and things like that. Palliative care can also be covered by insurance, but not necessarily. It's usually it's always covered while you're in the hospital, but having it for home is much harder. That's a separate designation, a separate team. So I wouldn't call a hospice company and say, hey, can I speak with just the palliative person? That doesn't happen. So who do you think would benefit? High-risk patients, people who are vulnerable, exhausted family caregivers, I think is really important. We don't forget about the family, but we sort of forget that the family has no break. There's nobody to help them. They're going to be doing most of the care. They're going to be doing all of the bathroom visits. They're going to be doing all the feeding. They're going to be doing all of the turning. And if you have a full-time job, or if you are in the middle stage of life, the way I am, where I had aging parents and I had little children that I had to move to school and shuffle with my schedule with my husband, things like that, it's a big predicament. And what do you do with those people who need support? Certainly patients who have lots of comorbidities, and then other illnesses other than cancer. We pretty typically only think about cancer, but there's lots of other things that would qualify for both of these benefits, right? Cystic fibrosis is a terminal disease unless you get a transplant, a stroke where you're not going to be non-recoverable, Parkinson's disease, Lou Gehrig's disease, things like that. Here's just pulled from MIMS if you have any interest in it. Here's 4 of them. So Casey House is what we have here in Montgomery County, and all of them are that inpatient hospice facility. So are we ready for this? Probably not, right? So we get called, for the 911, that patient is gurgling, they have a DNR. We're not sure that about hospice and palliative care has ever been sort of spoken with them, but we need to sort of have a conversation. So we're going to take them to the hospital. And if we take a patient, right, if we take a patient who's gurgling, even if they have a DNR, something will happen with them at the hospital, right? They'll get IVs, they'll get pain medication, but they'll also get non-breather mask. They might even get a CPAP, depending what kind of DNR they are. They might get intubated if they're just no compressions. What will they get pressors? Will they get treated for sepsis? Is that something they want to do? Is that something that we want to do for them? Do I really want to participate in a metastatic cancer patient or an AIDS patient who has, you know, a viral load that is going to kill them shortly and do that to them? I'm not sure ethically I have the mobility for that. Lots of patients just want to have, you know, somebody there with them and have a conversation. But you know, their family member does not know what it looks like when they have a mottled skin, or they have that death rattle, that sort of awful breathing, or they're going to the bathroom everywhere, they're vomiting everywhere. We do not have those conversations with people, and here's an opportunity to do that. So family members, right, we talked about are the people who are taking care of all these patients, but your new family will be, if they're enrolled in hospice and palliative care, might be able to help some of these sort of burdens that the caregiver has. Right? We all don't want to be a burden to our family members, but it was truly my pleasure to take care of my mother, though she did say, I don't want to be a burden. And I'm like, you took care of me my whole life. I'm happy to take care of you. So, but I could have used some more love and affection. I never saw the hospice nurse until my mom passed away. They showed up, it was during COVID, they left like a bag of medicine at the house, and I never saw them, right? I ordered the hospital bed. There was no education about how to give medications. I mean, thank God I was a nurse, but what if I didn't? You get a thing of morphine, you get a thing of Ativan, hope for the best, and a syringe. You're like, what if you're not a medical person? What if you're CPA? What if you're a waitress? What if you've never had any inclination to give a medication in your life? And then you see somebody who's basically unconscious that you have to give medication to when they have a death rattle. What are they going to do? They're going to call 911 and say, I need help. I need you to help me. I don't know what to do. So our job will be to not just help the family members as we're thinking about this, but those or the patients, but the family members when they call us and say, I don't know what to do. And we don't know what to say. So we don't have enough training. The patients are afraid of being alone, but we don't know what is happening with the patient. We don't understand palliative care. We don't understand hospice care. We don't understand how to call anybody if those patients are enrolled in those things. We feel like we have to hurry up and get them to the hospital or get a refusal or do something. The patients and the family members are feeling alone. They don't know what to do, sort of feeling like a burden versus going to the hospital. They don't really have a great plan of what it looks like. Nobody says to the patient, oh, you're getting enrolled in hospice. P.S. You're going to be suffering at the end. I don't know if you're suffering, if your mind is, you know, if you're unconscious, but at the same time, it feels like it when I'm watching somebody have a death rattle and it feels like they're choking and they're moaning and groaning. That feels like suffering. I didn't actually think my mother was suffering, but hearing that noise, if I was not a nurse, I would have flipped out. And I could just like know that ahead of time. So there's challenges when we want to do this. I hope, you know, at this point, you're like, man, we should be doing something with palliative and hospice care, but there's all the problems with trying to do it. There's a shortage of people who want to take care of these patients. There's a shortage of people who want to be the provider or the palliative nurse to say, yes, I'm going to help you with your passing. You have to, you know, go to anybody's house and be able to help them with that journey, which is a wonderful thing. But, you know, everything is about money, which sort of is just the nature of this country in healthcare. So there are these services, but again, as we saw, if you're in the city, you have the opportunity for these services, but if you're not in the city, you might be out of luck. Less than 50% of hospitals have a hospice or palliative care. But we have a great opportunity because we talk about patients are more satisfied, their family members are more satisfied. We're providing more support for those caregivers to prevent burnout for themselves and for the providers who are taking care of them. If I have a really firm grasp about hospice and palliative care, and I go on a 911 call with that death rattle, and I see that the family member is freaked out that this is happening, what a great opportunity for me, and really satisfying to be able to have a conversation with them, hold their hand and tell them, unfortunately, this is the way it is, but I'm going to be with you, and we can give a little supplemental oxygen if you want, and we can call the hospice nurse and have them come over, and we can, right, I can't participate in giving them their medication of the morphine and the Ativan, but I definitely can say, what medications did the hospice nurse give you? Let's go through them and see maybe what's the right fit. And then maybe there's something that you feel like would be a good opportunity now to give. So gosh, I am here to do emergencies. I don't want to do anything with this. I think this sounds like a terrible thing. You know, I'm Wheaton for Life. So that is our rescue squad. And then a picture from Silver Spring. So gosh, this is what I'm here to do. No. We're here for quality of life for the patients. So we are really smart. We know what we're doing. We understand symptom management. So now let's do something when we hear about this death rattle in their chest, or we hear that they're short of breath, or we hear that they're in pain. I know how to treat those things, right? I give them medicine and take them to the hospital. Let's go a step further and think about, what am I doing for them if I do that? Is that the right thing? And we're here for things other than the emergencies. So if I show up at a patient who either is not ready for hospice, but I think they might be, me taking them to hospitals is, going to be my job. I can't take them there, but I also have a great opportunity in the back of the ambulance to speak with their family member or with them to say, how's your quality of life? Do you feel like people are, supporting you with your pain? Is your pain managed? Are you feeling anxious? Do you feel like you have somebody to talk to? Are you getting up and seeing the sunshine, right? Those are such silly things to ask people, but how many times have we been in the back of the ambulance and it's quiet? We have nothing to talk about. We did all of the vital signs. We put them at the IV. Maybe we did a 12 lead. And then you have a lull moment of doing maybe not much. So you have an opportunity to have a conversation. And it doesn't mean that you're saying you should go to hospice or you should do that. But I think starting a conversation with a patient of like, where do you see yourself in a year? Where are your friends? Are they around to help you? How's it going? Maybe we could hook up with a social worker who's here to provide you guys with more support at home, right? You don't have to go anything further with that, but like put in their head that there could be another way other than just going to the hospital when things get hard, if things are going to continue to get hard and they're not going to get further treatment for their disease, or they're not able to walk now because they've had, there's terrible diabetes that's not getting any better. They don't want it to get better. They don't want to do their insulin. That might be somebody to say, how are you feeling about this? What do you want to do? Where do you see yourself going? Who's going to help take care of you, right? Just have those sort of basic conversations. And then if something comes up and the family or the patient says, man, I just don't want to do this anymore. I just feel unhappy. I don't want to go to chemotherapy anymore. I don't want to take my triple therapy for my HIV. I just want to be finished with this. I'm not going to say to somebody like, oh yeah, you should do hospice, definitely. But I might say when we get to the hospital, hey, this person has metastatic cancer. They're just mentioning to me that, their last chemotherapy was 3 weeks ago. They're feeling really bad. They don't want to do this anymore. I don't know them, I was only with them for 15 minutes, but maybe you could have social work hook up with them and see if you have any palliative care services that could just help them, right? I'm not saying the hospice word to them. I'm saying palliative care, which is about quality of life, prolonging as much happy life as they have. I think we have a great opportunity to do that. So, but why would we refer the patient, right? Isn't that the primary care's job? I think that we have probably all heard other people say, that's not my job. Somebody else should do it, right? I'm really not into that's not my job, right? It's all of our jobs. All of our jobs is to take care of each other, to take care of our patients, to take care of their families, to take care of the healthcare system as long as we can, right? We all went into EMS to help people, to learn more, to know about medicine, and to do the right thing for the patient and for the community, right? We all felt so good the first time we go on a call and the family member says, thank you so much, you really helped me, or you got a ROS back and you just felt like wonderful about it, right? So that feeling feels good with this too. So it's a great opportunity as you're an EMS provider to now just think outside the box of like, oh, I'm gonna give them the right medication, I'm gonna get their blood pressure down, and I know the right thing. And I'm going to take them to the hospital after I have intubated them. And even though they had a stroke and even though they have a PEG, man, I feel great. Do you feel great? I don't feel great doing that. So now I want to do something better. Now I want to do something other than take the patient to the hospital, which I'm happy to do. I want to look at the patient and go, what's your quality of life? What's going to look like for you next month? Where will you be? Will you still be in the hospital? I want to do better. So we talked about sort of our benefits of this. The most important thing on this slide is that after somebody passes away, their family member still gets 13 months of bereavement care. And that includes counseling, either of a licensed social worker, that could be a psychiatrist or psychologist. I mean, certainly they were calling me and sending me cards, which I didn't have the emotional bandwidth for, but I really appreciated they were trying to reach out because I'm sure it's really helpful to some people. So I think it's an important thing to mention if you go to some person's house, and make sure to have a conversation with them, not like, oh, when your loved one passes, don't forget you can still get help, but just let them sit in the moment that this is really, really hard. And it's going to be really hard for a long time. And it might be really hard forever. And so there's ways to have conversation of what really hard looks like and what their new normal looks like. And they have do a really good job of having an interdisciplinary team to think about those moments, because it's not just once the person dies, it's like, oh, that's it. It's all these other things. So all of this cost of hospice is still cheaper than taking the patient to the hospital and putting them on a ventilator and getting them into the ICU and then going, gosh, I didn't want to do this. And then watching somebody get extubated, a terminal extubation, talk about that feels really terrible. It's like, man, we did all the right things, it felt like, and then now we're doing this. And you watch them, it just is not, it's not ideal. So all of this, right, and going to the hospital doesn't improve their quality of life. During COVID, visiting hours might get messed up, so they might be alone. Are we doing the right thing for them? All of that, in addition to the emotional bandwidth of it, also is really expensive. And so if we could figure out a way logistically to have more hospice, more palliative care, more mental health workers in this journey of quality of life, it would still be less expensive than their hospital care. So now it's just going to
There are a couple of questions or great comments.
sorry.
That.
I see, I think one of the restraints in EMS is discussed a little bit is the pressures of spending time with family, given how many calls the service are backing up. We're sending medics frequently to the opposite side of the county. Yep. I'm both a paramedic and a social worker, and I've tried to make referrals in several different ways, and the lack of feedback makes me feel sometimes I've wasted my time. We're involved in their care, and we need an interpretation somehow that it's okay for us to get some feedback. And who's the lack of feedback from? Your superiors, from the hospital? Can you say a little bit more about who's the lack of feedback from? Oh, I'm not sure about that piece. I definitely will agree that, from anyone, okay. Well, from the hospital standpoint, I hope you're not. I would ask for the social worker on call, as I'm sure you know, at least that person is speaking your love language about quality of life. From the fire department EMS standpoint, I totally agree with you, right? Sometimes I'm like, hey, we're just gonna stay. And people look and you're like, no, we gotta go back in service. Why do we have to go back in service? I hear you, I'm hearing those calls. I do hear all of those calls that are happening, but I'm here right now and I can fix this thing right now. And so you have to sort of figure out what is the hill you're gonna die on or not. How long you've been in your position. Do you have the ability to do that? I definitely get when you're new, you feel like you have no voice and you cannot do those things. And I think having the opportunity to have these conversations when we're not on the 911 call, listening to the calls back up, to think like, what is my core value? How am I going to be able to tolerate this? Who is going to be my support system when somebody says, hey, we have to go back in service, when I'm here with a crying spouse, as I'm trying to reach the hospice nurse. And I don't know that answer. That's a sort of ethical decision, but also whatever your system where you work decision. But I think it's really important to talk about why, what's the plan going to be? And so you also write, like, been waiting to hear from an ER social worker and it didn't happen. They're also overwhelmed. Yep, everybody is super overwhelmed, and I really do hear that. And I don't discount that. I work in West Baltimore where we are all majorly overwhelmed all the time. So I can really appreciate. And it looks like Tangela, you have your hand up. Oh, you're on mute.
My keyboard is acting silly, so I couldn't put it in the chat.
Cool.
But I think what drew me to care management was this exact type of thing. It's helping people beyond the hospital, because not every patient needs to go to the hospital. And while we're talking about the time we spend on scene, I remember years ago spending about an extra 20, 30 minutes on scene, giving a patient referrals for like Department of Aging and everything. And it was a frequent flyer patient. After I gave them and their family those resources, or helped them with the numbers to those resources, those calls from that house stopped because they now had services. So while we understand that the county, the city, Montgomery County, everybody, every system is taxed, that extra 15 or 20 minutes trying to actually help them with the resources, you can give them pamphlets all day long, it's going to sit on the table. But that actual help, because they're scared, even when I talk to people over the phone from my office, it makes them feel better about, how they're handling their family member. And they do have support groups. Like you said, each of the hospice teams have counseling and stuff, but what if you're not in hospice or palliative care? There are a lot of resources. If anybody wants to contact me for support groups and caregiver groups for Alzheimer's, for whatever, for cancer, whatever, because sometimes it just feels better to sit in a group and talk, or talk virtually, because that other family member or that team may have an answer that you needed or you don't. So I really like this conversation because it, you know, as a paramedic for many years, I've always felt I had an outside interest in actually helping people beyond the emergency, is what I call it, beyond the hospital. So yeah.
Thank you. I really like that. And I think like you, this is the hill I'm going to die on. And I, you know, in the springtime, somebody called for anxiety. We went to his house. He's very, very anxious. He shows me his discharge paperwork from the hospital 4 hours prior. You know, they gave him medication. 911 had already been there. So this is the third time we're there in 24 hours. And the new EMT was like, I'm just going to take him to the hospital. And in 30 seconds, he said, I'm so anxious because I literally moved here yesterday from like outside state. He was from another country from 6 months prior. His sister was supposed to come over. She couldn't make it. He had never been in this town. He, you know, he was totally alone and he didn't know what to do. And when you have no resources and no help, and I'm like, we're just going to wait. We're just going to wait for the sister. I called the sister. She came over. They were like sobbing together when she got there. He just like wanted a buddy. And he just didn't want to be alone, right? Who wants to be alone? Nobody. And that was the hill for me. They're like, we need to go in service. And I'm like, I hear you. I do. And I support you. But I know I can help this person right now. And the next person might not need my help as much as this. And I just have to commit to like being in it right now. And I'll eat whatever, like you're going to be mad at me or write me up, whatever. I don't care. This is like the right thing right now. Shannon, right. I really appreciate where this conversation is going. No problem. So just think about in your head, like, I really do think if you can go do a little self-reflection of like, what's your core value, what's really important to you, and what are you willing to sacrifice to do the right thing or what you feel like is the right thing. And having the conversation before you're sitting at the patient's house when they're saying you need to go in service, you need to go in service, you need to go in service, to know who like, hey, this chief says he's going to support or she's going to support this process with me, and you're getting some feedback when you're on the call, you call them and say, I need to stay here. This is important. This is the reasons why, and have that superior person be there to support you on that. I think is really important. All right, so we're just going to review some myths, make sure everybody's on the same page. You have to be a DNR. Oh. True or false? It's both. So if you want to be enrolled in hospice, you do need to move forward towards your advanced medical directors of what that looks like. But you can be enrolled without formally being a DNR. It does need to be signed sort of before you arrive there. But if you're moving to hospice and you're in the hospital and we're getting rid of, you know, all of your blood pressure medications, your anticoagulation and things like that, you don't need to be a DNR quite yet. Yeah, so you can be a full code to enroll. And then inpatient facilities, so those like Gilchrist areas, Casey House here in Montgomery County, they cannot offer any resuscitation. They do not do any intubation. They do not call 911. They do not do any CPR. And then when it says resuscitation decisions is what's medically effective. So if somebody is like their blood pressure is 240 and they're having an extreme headache, they won't let that person sort of suffer with this 10 out of 10 headache and have a, you know, hemorrhagic stroke right in front of them. That would be suffering to them. So they could, in theory, give them some antihypertensive medications, but that wouldn't normally be in the guidelines. But because it's sort of about quality and suffering, that's when it would come into play. All right. So we sort of talked about this. Both services for can be for any patient. Some people think of palliative and hospice as caring less. And so I just want to make sure that as you're sitting in here, it's be like more. We're trying to get there as most quality of life as we can. We're trying to have the least amount of pain and suffering and what that looks like. All right. And so hospice will be with the patient 24/7. I hope that I proved to you that that did not happen. Right. They're definitely not there. Hospice is available. They're only a phone call away. But you know, the family is the one who has to commit to this journey, or their friends or somebody who really loves them who's gonna be like, I'm going to be in it to win it with them. Let's see. AJ said, oh, hey there, I'm social work. worker as well. While taking care of my mother, I connected with all the social workers so they understood I was capable of taking care of her at home on my own. But as a full-time caregiver, I truly felt that I didn't get enough support. I was blessed to be there for her, and I would do it again. Me too, dude. You know, I had no support, but it was the right thing. I have zero regrets about doing it, but man, the trauma from that was pretty major. Brian, hey Brian, my biggest peeve with hospice is that the MOLS DNR isn't always in place once discharged to the home. Shouldn't it be? I've had this scenario more than once. I feel as if the MOLS should be automatic and in place once a patient reaches this stage of their life. Additionally, I feel as if some populations are truly unaccepting of death and is unwilling to obtain a MOLS and DNR. I think that's a twofold piece. So I wonder, I don't know, but I wonder if that patient was truly on hospice, if they didn't have the MOLS in place. Certainly where I work, it's a really big conversation of like, if you're going home, here's the copy, here's an extra copy, please keep it in your wallet, please put it above, and sort of everybody's in agreement. In palliative care, you don't have to be a DNR. And so I don't know the circumstance of that. I mean, certainly I think some skilled nursing homes do have hospice overlay, and those I've had those circumstances where they didn't always have the available paperwork because the chart is not with the patient, things like that. But I would agree, great opportunity too. If somebody's enrolled in palliative care or in hospice, like can we take 2 seconds to get all your paperwork together? How can we help you with this? Do you have a binder that you keep? Things like that. Last piece, additionally, I feel like some populations are truly unaccepting of death and are unwilling to obtain a MOLS and DNR. I totally agree. And I'm not here to like have a deep conversation with somebody when they've called 911 about whether they should be a DNR or not. My job is to like say, are you happy? Do you feel like your quality of life is the best that it could be? Is there anything I can do to you with you to support that journey with you? And they're like, nah, I'm good. Okay, I've offered and I'm glad to be there with them. And I usually say, and I hope that somebody will keep having the conversation with you because that might change sometime. And that's okay too, right? We all have a right to decide when we're ready to sort of be ready for the next step of our healthcare journey or not. Jack says, besides the MOLS DNR, is there any other hospice specific documentation to be looking for? Nope. So that's the one in Maryland, certainly. So advanced directives don't count. Any other sort of written piece of documentation does not count. You have to have the DNR or the with the MOLS on there, and that's what hospice needs to do. And so, right, hospice is the drop-in service, which we talked about. And they stagger their visits as, you know, how it seems fit with the patient and their family member. And then if the family cannot, for some reason, the social worker, and certainly for those of you who are social workers, you might be able to arrange for residential hospice care. So certainly if somebody doesn't have anybody, right, they don't have loved ones or friends, but they would qualify for it normally, that might be somebody we would look into a residential facility so they had more support. You know, nobody can help it if they have been alone or their loved ones passes away or they moved here for a job and then suddenly got metastatic cancer and are on this journey by themselves. So you might end up being part of their family as you're helping them in this new transition. So we try to figure out the best possible way we can. And then we talked about this. So you need health insurance to be enrolled in hospice. So you don't need health insurance to have hospice. Some for palliative care you do, and that full-time 24/7 hospice at home you do. But the rest of it is all part of everybody's commercial health insurance. That being said, if you don't have health insurance, our job is to help you either get health insurance or they can still enroll you. It's not a requirement. Let's see, so many myths and not know information. Thank you. A patient waiting for transplant could be DNR palliative only. There might be treatments they could have. There could be treatments they couldn't have or shouldn't have waiting for an organ. So many categories all at once. Oh yeah, I mean, if you're a transplant, if you're waiting for a transplant, if you're going to surgery, you cannot be a DNR when you go into surgery because your expectation when you're going into the operating room is that if something were to happen, then you would be taking the risk to, you know, that happening. You sign a surgical consent to say that. If you're waiting for a transplant, you have to be a full code. I know that I worked for transplant for a long time, but you certainly could be palliative, right? You certainly could be having like making sure that somebody's thinking about your quality of life as you're waiting, right? 50% of patients who are waiting for an organ transplant die waiting. So those people definitely need to have some support as they're waiting on their journey too. So barriers, right? We're all sort of in this barrier system, right? Sometimes we're really uncomfortable talking about emotions. Sometimes we're worried the religious thing will come up. Sometimes we're freaked out about dying. Sometimes we have no idea what the patient is asking and you don't want to seem stupid. Sometimes we're just not taking the time, right? I think we've all talked about that we're feeling rushed, or we don't feel like we have the knowledge standpoint to have a conversation. So how do we talk about it, right? Try to do anything you can to improve your communication with patients. And then how do you feel talking about end of life decisions? So do you feel uncomfortable talking about it? Do you feel comfortable not talking about it? Why are you here? Are you here for the CME? That's cool. I've signed up for many classes for the CME. Or are you interested because you want to try to get a little more comfortable or get in the uncomfortable with it? That's what I hope that you did here. So what's the National Registry say? They say basically nothing, right? So there's nothing in our initial curriculum. It's very, very limited and it's not formal at all. So I like this study. 2002, a survey was mailed to 200 EMS programs in US cities, and only 7 of them had any palliative care protocol or conversation. I don't know why, sorry, the formatting came out pretty wonky. Nova Scotia sent out a cool survey, and then all the paramedics thought that palliative care was important. And that we should be able to provide it in some way. Wouldn't it be awesome if we got a 911 call for somebody who was like doing some death rattle and they were not doing great and they were enrolled in hospice and they were out of meds, and we were able to call the hospice agency and a little bit of base station and give them some Ativan and some morphine to help them like ease their suffering? That would be awesome. So what can we do? So 40 million people require this, but we currently can't do anything in the great state of Maryland unless you're in community medicine, is where I got this passion to do this. So we're here to start the conversation about it. That's all we can do currently in the state of Maryland. So have you thought about what your choices are? Have you thought about what a good day looks like? Have you thought about what quality of life looks like for you? Do you know what you want to do as you transition towards things getting worse? Oops, sorry. Last one. So talking about those options, right? And again, you don't have to go into strong detail if you don't feel comfortable with it. But I think with every single patient, saying to them, is there anything I can do for you when we get to the hospital to make your time there the best that it could be, and with as least pain and as least suffering as you can, right? We usually can say those things and feel okay about it. Russ says, I find that education given to both ALS and BLS providers teaches almost zero. Most don't realize DNR isn't a patient decision. Isn't always a patient decision. Do you mean their family members can do it? Maybe either type it or say more about that. I'm not sure. And then Jack says, can this conversation be continued by an MIH referral? And we'll talk about MIH in just a second. So part of my work is through MIH. I was really interested in the Baltimore City Paramedics, where we do our mobile health. So myself, Sarah, who's another MP, and Dr. Gingold, who's our medical director, said, these paramedics are really smart. They are all joining MIH because they want to be there. They're all really interested in community paramedicine and trying to do the right thing. If you're not familiar with our program, 50% of it is treat and street. So nurse practitioner or physician arrives in an ALS chase car with a paramedic. And then the other half of it is seeing high risk of patients for readmission who are voluntarily enrolled in West Baltimore, and we help them for 30 days after discharge as they transition home. But lots of these patients have lots of comorbidities. Lots of these patients could have had a definition of a hospice designated diagnosis or even palliative care. And the paramedics were like, man, we don't know anything about that. What are we going to do about it? So that's why I became interested in it. So all of the paramedics before and afterwards, they thought it was really important to have communication, and they thought it was important to have these conversations, but they didn't feel great about it. But after we did an intervention where we gave them a lot of palliative care education similar to this, lots of them felt much better about it, which we really were hoping to do. Same thing, sort of pre and post. We were totally into taking care of nausea and vomiting and giving medications and having conversations with them and like treating symptoms, but we were not really into the communication and the emotional standpoint. So that was the point of this. So here's our chase car and just a few case studies real quick. 67-year-old guy was admitted with a UTI and failure to thrive. He was transported to the hospital via 917 days prior. He has a history of TBI, dementia, CVA. And before he got to the hospital, he lived at home with his sister, who was his caretaker, and she reports that he's typically alert, but not verbal. So he was discharged home. He was enrolled in our program, as well as with home hospice services. And hospice hadn't started yet. As we talked about, 90% of the time is done by the family members. And we try to show up within the first 2 days after their discharge. and we're here to see him. And so we're there. The sister looks a little bit rough. I remember this call. The patient is laying in bed. Vital signs are sort of unexciting. The sister says he's always nonverbal. He just ran out of some of his meds. They can't afford it. Excuse me. She cannot take him in and out of the house because he's basically like dead weight. She starts crying. She's feeling overwhelmed. She's feeling like really bad that she hasn't done the right thing. And she calls 911 because she feels stuck. And so what is an opportunity here that we see that he's enrolled in hospice? And so let's call the hospice nurse and say, hey, I know you haven't started, and come over to the patient, but we're sort of at critical mass here and we need to do something. Otherwise, we're going to need to take him to the hospital, to at least treat his symptoms if he's having any, or if the sister has hit sort of her critical peak and she's not able to basically take care of herself or him, then leaving him there would be a difficulty too. So I don't want to have these conversations. I'm feeling overwhelmed by the emotion. I'm not into having, sort of quality of life conversations, but with those do happen. And so our job here was just to offer her support and see what she needed and how we could help more. And then if I don't know what to say and I'm just feeling stuck, you can just sort of be, use your nonverbals and just be as present with them as you can. Paramedics are these highly skilled people that were able to do these things and we just haven't been tasked for. And so I would encourage you to reframe your mind to go, gosh, I can do this work and this is a conversation I could have. So hospice with MIH, we're able to provide the patients and family with educations. We're able to connect them with resources, which is really cool. We had a social worker and a case manager on our staff as well as a pharmacist. So we were able to do that. Let's see, Sean said, was asking Russ to say more. Me too, if that is available to you, Russ. I'd love to hear more about that. But here in our MIH model, which I hope is continuing to happen in other counties, we're there to sort of be an extension of both the hospital and of the primary care, as well as be an advocate for the patient in real life and in with them as they transition into their care. So as we are seeing these patients, who's their hospice provider? Can we get their phone number? Can we call them? Where is this MOLS form? And then providing them like, hey, do you have a list of what you need to do if something happens? And who's going to support you if you need to go to the grocery store? And what are you going to do if your patient changes? Or what are you going to do if you need more help? Things like that. So talking to hospice, right? Having, how can we work well with them? And this would be in this community paramedicine, or as we're reframing our minds of what paramedics can do, how can we help them? So with MIH, we were able to stagger our visits around the hospice agency and the skilled nursing agency, so that somebody was with the patient every other day, which was great. And it allowed, so when we would come in, we would be there for about 45 minutes. The sister would literally go sit outside and just have coffee, so that she was able to like have a little bit of space and breathing room, right? If I'm there, she doesn't need to be there to supervise if she trusts us and knows that we're there to provide compassionate and high quality care. So if I don't have time to call hospice, I'm there as a 911 call, right? Says who. And this is when we try to have the pre-work, the conversation before you get on that call to say who's going to support you if you want to try to do something different than take them to the hospital. So we want to provide the best care that we can, and we want to do the best thing for every patient every time. And I can assure you, you are going to make mistakes. I have made tons of mistakes. And in retrospect, I wish I had done lots of things differently, but I can't. So all I can do is say, well, I want to really, know more about this and then teach other people about this and why it's important. So if you think about these questions, so hospice is defined, we sort of know all of these things, I hope, were support and care in their last phases of life. Because delaying treatment, though, in an emergency is much more serious. So if you're not sure, right, then we're just going to treat them. So if you're not sure if they're hospice, or you're not ready to have a conversation, you're not sure if they're palliative, or you can't find that MOLS form, we're just going to take them to the hospital, and then, right, because we're always going to err on the side of caution of doing the right thing. So all of this is about sort of doing the right thing for the patient, trying to figure out what that looks like for them. Right? The patients can refuse to do the right thing or what you perceive as the right thing. And I think that's really important to think about. As I have grown more in age and experience in healthcare, right? Everybody has the right to do the wrong thing. Just because it's my right doesn't mean it's their right. So am I doing the right thing with their body? Am I doing the right thing with their care? And am I allowing them to have their own journey in their health and have their own way of doing it? Russ says, is venture say most are hospital bound, but family doesn't always want to start. Family doesn't always want to start. I think you mean DNR order. That is true, right? Family members and patients are not always on the same page. So I really try to make sure I'm advocating for the patient, but having a listening ear to the family members. But at the end of the day, right, our job is to do whatever the patient wants to do, even if their family is not in agreement of it. I think that's what you're saying, Russ. Right, this is when in doubt rule, right, do the best interest of the patient, worry about it later. I think we all know that. And is this decision reasonable, right? 75-year-old patient with terminal lung cancer, family got nervous, called 911 after shortness of breath, maybe heard a little death rattle. His pulse ox was a little bit low. He tells you he's on hospice. Oncologist says he has no treatment. I'm going to die. I understand this. I've come to terms with it. My family's scared, but I'm ready. And that is a reasonable decision, right? He is a grown-up. He seems to be oriented. Yes, he's probably maybe getting a little bit confused if his pulse ox continues to drop, but it is really, really, really scary being there, watching this happen. So he seems to be a reasonable decision. And so you're just going to get a refusal and walk out and leave this family, you know, crying and hysterical. I hope not. I hope that you are calling the hospice agency and saying, we think something is happening. He seems to be, his oxygenation is getting lower. I'm going to give him a little bit of oxygen just to boost him up and get him back in bed and get him cool and calm in a position of comfort. I'm going to give him some oxygen while I'm doing this. And then we're going to need to go back in service, right? Because that's a thing. But you're going to try to do those things from a comfort standpoint as much as you can. Here's our MIMS protocol. If you forget, don't forget, you can take them to an inpatient hospice. So if you picked up that guy and you called the hospice nurse and say, oh, he's been waiting for a bed, we have one right now at Gilchrist, you can bring him there. Could you please? Right? We're allowed to do that. So don't forget, you can do those things too, right? Go one step beyond of taking them to the hospital and just getting them there. And somebody already asked this question. I think we answered it, that you have to have the most. So implications for us, right? We can do better. We can learn more. We need more training. We need National Registry to give us more training. We need our continuing education to not be the same diabetes, hypertension, you know, airway resuscitation that we have all been getting for long periods of time. So I love doing things like this because I think it's, we're thinking about something else. So, right, palliative care is an approach that improves the quality of life of their families. It's not the same as hospice care, and it does not mean do no, and it does mean do no harm. Hospice is almost always cover insurance. The almost always is the 24-hour hospice care at home is not always. Palliative care should be, but it's not always. Which person does most of the in-person? I think we've all, you've heard me say about 50 times that it's always the family member. They do 80 to 90% of it. These people are available to you, but they are usually not there with the patient. How can we become more familiar? By knowing all of these. Be a listening ear, promote effective and compassionate care, understand the difference of what's there, and that is it. There's also a CME on the MIMS website with a lot of the same information that is from us as well. So if you have any questions about that, otherwise it's another free hour of CME. And thanks for having me. Any questions?
Wanted to get the link out for folks to start signing up for their CEUs. Yeah, what an incredibly important topic. You're right. We've been running this program for about 4 years, and I think this is only the second kind of topic along this line. You know, for those who don't work in the hospital, I mean, I just can't, just like Suzanna, I can't begin to advocate enough for our palliative and hospice colleagues. You know, I work in an intensive care unit. There's a lot of advanced cancer. There are a lot of patients who, who need hospice or who need palliative care and hospice care, but yet there are all kinds of barriers, just as you mentioned. So facilitating those conversations, helping to really help them understand that hospice and palliative care does not mean giving up in any way, shape, or form, right? It's just totally changing the focus of care. And I got to tell you, you know, as an ICU provider, I must admit, I judge that the palliative care team that sees these patients every day focus on the things that matter more than the things that I do as an ICU doc, right? So I'm very quick to treat heart failure, sepsis, all that, you know, support the ventilator, the dialysis. I can do all that. But I don't go in and talk around, you know, the itching that they're having because of the narcotics or the constipation that they're having, right? It's just not a focus. So for whatever that's worth for providers, you know, in hospital, you know, palliative care services, they are special people. Yeah, an incredibly important role.
Well, if anybody has any other questions, hang out for a little bit. Thank you for participating. Some of my OGs from Montgomery County are here. Thank you guys for coming. It's nice to see you.
Suzanna,
having
thank you so much. And yeah, thanks for sharing your email and your slides. And we super appreciate all that you're doing. Have a great night and enjoy time with your kids.